Expo team. I'd like to welcome everyone in attendance to Eye to Eye Series Coffee Talk. So welcome everybody. For
Got
those
my
of
coffee.
you who, I was going to encourage you to bring your hot beverage of choice. I apologize for not warning you ahead of time. So I want to welcome everybody to Coffee Talk. If you do not know me, my name is Terrence Lackland, the Director of Partnerships and Programming for the Vision Council. This is actually our third Coffee Talk, and some of you have stuck in, been here every week. So thank you all for your support. I see some familiar names. Sean Hahn, thank you. Dr. Noel Henry, we've never met, but I see your name here every week, so appreciate all your support. So just a few housekeeping issues. So we're using the Zoom software. We decided to use this platform because we felt that Zoom gives us a more sense of community. We're able to see each other, we can participate as well. But in order for this session to go very organized, we ask that everyone, if you're not the panelist, to keep your microphone on mute. You should all be mute right now. And if just watch your microphone and make sure it's always on mute as well. Now you will have an opportunity to participate. So if you'd like to ask a question, go ahead there and in the chat box, go ahead and type your question there. Or during our Q&A, if you'd like to ask a live question, you can use the raise your hand button, or you can type me a message to me personally, and I will unmute your microphone and you can go ahead and participate in the conversation. So, but nice to see everybody on. Hello, Virginia Beach. Hello, Chicago, Hoboken, Arkansas, Toronto, people from all over. We'll do another roll call after the session's done. But I want to welcome you to this week's Coffee Talk. We're very, very honored to have this Coffee Talk brought to you by the American Telehealth Association. We have Dr. Bryan Rogoff and Dr. April Maa. And for the next few minutes, they're going to speak on incorporating virtual care into your practice during COVID-19 pandemic. So I'm going to turn the attention over to Bryan. Bryan, you have our attention.
Thank you very much. It's certainly an honor to be able to present this type of topic to everyone on the platform here, as well as to be able to present this with Dr. Maa, as she has some real great experience to bring forward when it comes to, well, ocular telemedicine. We're going to go into different definitions. And so, again, I'm Bryan Rogoff, Senior Product Manager of Disease Management for ZEISS Meditech. And Dr. Maa, do you want to introduce yourself and what you do?
Yes, so I'm welcome everyone. Thank you for attending our webinar, and I appreciate the ATA asking us to host this. So my name is Dr. April Maa, and I'm an Associate Professor at Emory University School of Medicine, and also work for the Atlanta VA. I have the privilege of working with our veterans, and I belong to the Regional Telehealth Services line that belongs to Vision 7. So we do, in my service line, all we do is telehealth of all different kinds for all different specialties. So it's a pleasure to be here. Thank you.
So we figured we were just going to start to go over some just general terms, as it seems like the COVID-19 crisis has really pushed general eye care overall into be able to start utilizing telemedicine in some sort of capacity to be able to help our patients and to be productive while we have shelter in place in some states and what have you. And I've been in the telemedicine sector, kind of working with different companies for the past 5 years, and certainly seeing it struggle to make it into the private practice and more of where we have a lot of access to healthcare. And so, and Dr. Maa certainly has the experience of bringing it into the VA system. So we wanted to clear a couple of things up. So we're going to go through some of the presentation here. And we're just going to go first through an introduction and overview of telehealth and virtual care. And some of this, you know, Dr. Maa, myself, we're going to be explaining how we think about telemedicine in different capacities, as it's more of a global tool than just a tool that we're going to be using here in the United States. And we have a particular idea on how we're going to use it for patient care and how we're doing it now ourselves. So first thing I like to always go over is the words and the terminology. And Dr. Maa, myself, have discussed this, and you can kind of call it whatever you want, but you might see certain literature that comes up where it talks about telehealth versus telemedicine and mHealth and all these different terms. And so it's a good, at least to have a background in how we'll be using some of this terminology throughout this webinar series. So telemedicine has many different definitions, and just going over that, I mean, broad definitions. It's a remote treatment of patients by medical professionals using telecommunications tools such as telephones, smartphones, and computers. Now, it's very broad, and certainly this COVID-19 crisis, that's literally what we're doing. There's not a lot of regulation or anything like that. I've always used, and I like to use the World Health Organization, because for me and Dr. Maa, I don't know about for you, we did talk about this a little bit. I've always said that telemedicine has to answer three basic things, and that's to increase access of care, have better outcomes, and to lower costs. And I know, Dr. Maa, is that the way everything's sort of done at the VA system, and the way you kind of teach things at Emory?
I think telehealth is encompasses many things, just as you said, Brian. And I think that what you're listing are many of the benefits of telehealth that we're well known and that we believe in. But I think the definition that you have listed there is a very accurate definition. Essentially, just think of it as anything that allows you to help care for your patients or monitor them when you're not in the same space as them, you're not in the same room as them. So yeah, I agree with.
So we definitely like that definition. The World Health Organization, because it's done around the world in different capacities, they really go into a very detailed, but also broad application of telemedicine, because it's the delivery of healthcare service where distance is a critical factor. So that's not necessarily the case in the situation we're in now, but all healthcare professionals using information communication technology for the exchange of valid information for the diagnosis, treatment, prevention of disease and injuries. It's also done for research and evaluation and continuing education of healthcare providers for the interest of advancing of the health of individuals in the communities. So as you can see, that's a much broader, more global definition, as they want to make sure that they're able to utilize that terminology for telemedicine in any capacity that they're doing. Typically, when I've lectured about this, I'd like to go into a little bit more definition, as telehealth versus telemedicine is used interchangeably. If you get into some of the technology side, and some people who are really knee deep into it, they'll tell you they're two different things. And so over the years, they've kind of been used back and forth, but in the beginning they weren't. And really, when we start to think about telehealth versus telemedicine, the telemedicine side is really when we start to think about the clinical application. We start to think about remote clinical services, improve patients' clinical health status. So you have your follow-up visits, your management, chronic conditions of medical management, specialty consultation. So that's really where we're doing a lot of this work here, and Dr. Maa is as well. Where we start to talk about telehealth, that's a much broader type of topic. Those are more your non-clinical services, preventative and promotive and surveillance of health promotion and public health functions. So when we start to talk about telemedicine and telehealth, we want to think about, as we're starting to think about the definitions overall, and we start to talk about, you hear ocular telehealth. You're putting broad definitions in there, but the people that are knee deep in it, they really will distinguish between the two definitions. And if you want to look at it as a graphic, I mean, we have the patients down at the bottom, and you want to encompass your overall health. You can see that the telehealth side there on the right-hand side that's the preventative and promotive type of applications that we're using. And then telemedicine is more the curative and clinical approach to healthcare. So as we start to think about this, we want everyone to understand some of the definitions that and the way we're using the terminology overall. In addition, there's different modalities, and telemedicine overall had many different ways of going about it. Telemedicine's been broadly used and has been successfully used in other types of health professions, such as it's been championed really by psychiatry as well as radiology. And so there's a lot of things that we can learn from what those two professions have incorporated telemedicine over 20 years plus to really make it a possible way of treating patients and also handling a lot of clinical situations. So really, when it comes down to telemedicine modalities, we think of 4 different categories. The first one is mobile health, and that's more of your telehealth type of applications, but the modalities for telemedicine to handle patients clinically, we have 3 different categories. First one is remote patient monitoring. This has been used widely, also known as telemetry. This has been used in hospital systems for a very long time to manage patients from a distance and to get real-time updates. We'll go into a little bit more of that. Store and forward, this has been utilized in many different ways where your pictures are being taken, they're stored in some place and then forwarded to the practitioner. And Dr. Maa has a lot of experience with that. And then a lot of times we think of telemedicine as just the live video component, but there's really 3 parts of this altogether that if you start to incorporate these different types of ways to put it into the practice, not only during COVID crisis now, but post-COVID, and how you might be able to utilize this to increase your efficiencies, be able to see patients while we have to keep a 6-foot radius from the patient, as we want to keep down infection control, and also to protect the safety of our staff and what have you. So these are different ways you can start to utilize this. And so, so for mobile health, you know, this is evolving type of healthcare service. This is data from your mobile devices. Some insurance companies are starting to use this to lower premiums if you give them access to it. I know that there's several insurance companies out there that will, if you give them access to your smartwatch, or if you are able to measure on a scale your BMI or what have you on a daily basis, you can earn a certain amount of dollars towards a flex spending account. I've seen different capacities on how they've done that. And that's really to monitor on a day-to-day basis, or at least on a more frequent basis, the overall health of your system. So the FDA, FTC, and HHS, they kind of all control this depending on how it's implemented and how it's being used. And they all have different ways on how they start to give instructions on the usage of that. So going a little bit further here, when we talk about remote patient monitoring, like I mentioned, this is more telemonitoring. This is more for these chronic type of conditions, or the conditions that are going to last a little bit more than in the acute phase of any type of disease process. So the way it's been used before is for blood pressure, blood sugar, weight, heart rate, and you probably see plenty of commercials on TV about how to monitor blood sugar with some applications. All this is considered remote patient monitoring. And I know Dr. Maa, myself, we were just talking about how in eye care there are some home remedies that or home monitoring devices that have not necessarily been cleared, but they're certainly on the horizon that you might have heard about. And Dr. Maa, I think we were talking about the ways to mend for glaucoma care, as well as there's home OCTs that are being produced, as well as pressure. Have you had, does the VA allow you to start to use anything that's not FDA regulated to be able to test and to be able to do clinical trials about?
You know, it's a really good question. There's been some, FDA sort of relaxing some of the policies on that. And I think that from a patient care perspective, as many of us are, providers, you have to be careful about using devices that are where if you're going to try to use them for treatment purposes, I think you have to be really careful about whether or not the data you get is reliable. So one of the things that we talk a lot about on our team is, with telemedicine, you are highly dependent on the information that you're receiving, that data has to be has to have high fidelity. Because otherwise, I like the term garbage in, garbage out. So if you're not getting good information from either the patient or the device that you're trying to use or something along those lines, then you're going to inadvertently make poor, maybe not make the same kind of decisions you would if you had gotten good information. So I think that's kind of important when you consider using technology that may not be completely vetted.
Yeah, that's a great point when you start to think about how you want to get the data and compare it to what you might have gotten also in the office. That's very good. And we'll go over different testing that as you might be able to perform via telemedicine to be able to hit some of the points, to be able to measure against, and to be able to manage some chronic conditions overall. So going from remote patient monitoring really goes to store and forward. And this is also known as asynchronous ways for telemedicine. So this is when images and documents and lab results can all be forwarded up into basically some sort of data repository and then brought down for later access from the provider to go over and review. And as mentioned before, that radiology has really took champion on this quite a while ago. And as CMS started to reimburse for this back in the late 90s and early 2000s and really expanded upon it all the way through the past 20 years, that it took real learning phases from radiology and as well as psychiatry. So the nice thing about this is that we do have ophthalmic instrumentation that can help us do this. And Dr. Maa, I know that the VA has been doing this for at least 10 years. Is that and I guess discuss some of the learning things that you've had when it comes along for all those years.
So, I mean, the diabetic teleretinal screening in the ocular field has probably been the largest and most well-studied and validated store and forward or asynchronous type of telemedicine. And I think that for the ocular care field, for our field, really we are a very, highly dependent on pattern recognition for a lot of diagnosis of disease. And we do a lot of different tests that lend itself to telemedicine very well, such as collecting information from an OCT, for example, or collecting information from a visual field machine. So all of these data points that are really important for caring for patients can easily be done in one place and then transferred to the provider who might be somewhere else. So I think our field is very conducive to store and forward telemedicine. So there's definitely some benefits to the next type that we'll talk about. Yeah, you're going to talk about in just a bit, Brian. But one of the things I'd like to observe here is that I do feel like for the purposes of efficiency and potentially expanding your practice's capacity, especially at this time, when you maybe don't necessarily for health and safety reasons want the patients to be sitting in a waiting room, crowded together to be seen in person, where I think an asynchronous approach might be worthwhile to explore.
Yeah, that's a great point. And I've heard a lot of different, some social media chat boards and just general things. A lot of people are out there, they're trying to figure out how to incorporate and what to do. And they hear about telemedicine and they're utilizing different applications. They're putting things together and they don't feel comfortable about it. So store and forward is one of those things to really think about, getting the information from patients. And it doesn't necessarily have to be from an OCT, doesn't necessarily have to be from a retinal camera at this point. But, and we'll go over some of the billing things that you can start to get images and acquire them. Certainly triage is a great way to start to think about this. But the next one, the next category what we'll go over is the live video, the synchronous. And this is where there's a direct real-time communication between that's usually done by video conferencing and audio. And I have down there all software must be compliant with the HIPAA regulations. Certainly during the COVID crisis, HIPAA has basically downgraded to be able to have any type of discussion with a patient. And there are certain things that need to be initiated at first, but certainly telephone calls, any type of, certainly like a Zoom chat like this, that's not necessarily HIPAA compliant and has all the BBA agreements with who, where this is being stored and what have you. None of that, you don't receive any penalties at this point. So we'll go over some of the requirements that go into that. But even right now, is if you can figure out a way to be able to communicate to your patients, it's some data is better than no data, as they say, especially when everyone is keeping shelter in place and trying to minimize their contact with other individuals. So, and I know that Dr. Maa has a lot of experience with this, as the VA system certainly has satellite type of locations where they not necessarily have any type of eye care for optometry or ophthalmology in those locations. So you're performing some of these synchronous types of visits with those patients as well?
Our system uses a great deal of synchronous telehealth, not so much in eye care, but more in for teleprimary care, for example. That entire exam can happen via synchronous video. So it's definitely a good option. And I think here I would encourage our field to sort of, because of our unprecedented time that we're in right now, encourage you to think about creative ways that you can use all of these telemedicine tools in your own practice. Because no, it's not going to be perfect, and no, you as a eye provider, you cannot see we have yet to develop a device. If anybody knows of one, please share. That can help you see the patient's retina through a video cam. But there's still useful things that you can get. So I encourage our team to our eye care field to think outside the box, think really innovatively. And I think we're a very innovative group. So this is a really good opportunity for us to think outside the box.
It's funny you mentioned that, Dr. Maa. I've seen some videos. I've looked up a couple of cameras myself that you can attach to the smartphone.
Right.
I think they go for about $300 or $400. You really have to hold it up, and Lord knows that you have to be steady and not using any type of dilating drops. It's really difficult. So I can only imagine how it is. I've also seen some creative people use some dilating drops and use a 20 diopter lens and using the camera.
Yes.
I've seen different creative solutions, but when it comes to people that you're trying to manage chronic disease states, this is going to be a little bit more difficult, as there's usually some sort of visual impairment as well as dexterity that's involved to get some of this information.
Right. And I think patient population also, it goes back to the same sort of comment we made earlier about getting good information. So if your patient is very technologically savvy and can get you those photos of very high quality and text them to you or get them to you, then you're going to get a lot better information. Whereas you may have a older patient that might not be quite so savvy, or may not have someone who's able to help them or assist them. We treat a lot of elderly patients in our system, and we do notice that sometimes that technological barrier is something that unfortunately you have to address appropriately to make sure you get good enough information. So Bryan, there is a great question here, I think, that leads well into what sort of the meat of our discussion from Bryan Kessler. He asks, what does ophthalmoscopy and retinoscopy look like post-COVID while social distancing is still in place? So it sounds like a good segue to me to kind of jump into some coding, and then also from the coding jump into some practical tips, because I think that's what we know there's going to be a great deal of interest in today.
So if you want to take that, because that's a really good question about, I guess we'll go into that as we get into some of those testing, because I know we have a couple of things we want to stay on track. As mentioned before, we have regulations and licensure, and when it comes to optometry, and there's different state licensure, and those different state boards regulate certain ways on how you can handle and be able to perform telemedicine visits. Some of them actually have written it into the regulations, as I mentioned, and some of it cannot cross barriers. I know that there has been a relaxing of some of this as well to be able to handle, at least I know on the medical side, if you have a medical license in some of the different areas, and then be able to cross over. A lot of that's been relaxed. But then just to go into some of the HIPAA compliant, as things start to get post-COVID and we're starting to see non-essential eye care, and HIPAA then gets back put into place, really the two rules that apply for telemedicine are the same rules that apply for us seeing patients on a regular basis as in office. So the privacy rule really focuses on the use of disclosure of the patient health information. You have to have protocols and procedures in place that protect all PHI when it's received, handled, transferred, and shared. And so the same thing comes with telemedicine, and you have to have the minimum PHI necessary to care for a patient. It sets limits and conditions on the uses and disclosure. So all that still goes into play when it comes to telehealth. And again, for the security rule, basically standards to protect the electronic personal health information, and there's 3 areas overall, and that's the administrative side, the physical and technical side. And it basically is just to ensure the confidentiality, integrity, and security of the electronic patient health information, regardless of the entity creates it, uses, and maintains. So getting into HIPAA compliance, also that security rule, it also goes into place on the application that you use, where the data is stored. You have to have those BBA agreements and everything. We didn't want to go into really that meat and potatoes of HIPAA compliance, but when you start to think about those applications, you want to make sure you do your homework, make sure that it is HIPAA compliant. So I know this is the section that everybody wants to know a little bit more about, because reimbursements, it's like, this all sounds nice, but how do you get paid, right? That's always the practice management side. Now, I know Dr. Maa and myself, we have discussed some of the things about reimbursements overall. I'm not a biller and coder, but I certainly have a little bit of background of understanding what reimbursements would then be applicable to telehealth. And I think Dr. Maa also has it, as she does code with within the VA system as well. So we'll go through this. There are a lot of resources out there, I must say. You can just simply go on CMS. Now, CMS obviously is for the Medicare side, but when you start to talk about the private payers with United Healthcare, Cigna, Aetna, Blue Cross Blue Shield, I would go to their resources, as also they have different type of reimbursements per state and the different codings that are necessary to be able to get through this time. So really check with those private payers, especially as those patients that present themselves to be able to do some of these telehealth visits. You're going to want to know what the codings are to make sure that's done. But a lot of them will follow CMS to a certain point. Now, when we start to think about things, they created these virtual check-ins during this crisis. And so a couple ways this could be done. It could be done in store and forward, the asynchronous way or the synchronous way. And this is video, usually about for 5 to 10 minutes. And also images can be obtained during this time. These have to be initiated by the patient, these virtual check-ins. And it can't be within 7 days of the last visit, and can't be within 1 day of the next visit. So it is a little bit restrictive on how to do it, but it's also just a check-in to kind of see in between the visits overall. And this one, you can basically use a telephone, texting, or a patient portal of your EHR system. And so it is fairly easy to do these check-ins. And the two codes that are based upon that is your G2012 and your G2010. Now, the G2012, that's more of the brief communication using more of the video. And as you can see, it pays about $15. And then the G2010 basically is evaluation of recorded video. So you basically getting the evaluation portion of this. Now, the reason why there's an asterisk there is because you can do the evaluation and then do a G2012 as well. So you can get a combined, from what I understand, when it comes to virtual check-ins. The next ones we have is e-visits. Now, this basically is more of a time requirement that is basically going on. It's mostly for established patients. I have seen some literature where it says some new patients, but then again, I don't know how new patients are going to be able to do these e-visits, because it basically is still the connection between the physician as well as the patient. As you can see under the technology, it has to be, this is more the HIPAA compliance side, that it has to be through an EHR portal. You have to have secure email and secure type of messaging for these e-visits. And these e-visits are basically, they're coded based upon the time that you're utilizing here. And the one thing about an e-visit is that the time gets accumulated over 7 days, but usually not more than 7 days. So if it is just one visit that was within about 5 to 10 minutes, you can see the reimbursements on that side of $15. If it's 11 minutes to 20 minutes, it's about $31. And of course, if it's beyond that, then it's about $50. And like I said, this is an accumulation of these visits within 7 days. So that's another type of code that is being utilized for the telehealth and the e-visits. And the next one is more the telehealth services, where we start to think of how to perform. And I think this is a lot of what I've seen a lot of colleagues and a lot of people struggling with on how to be able to handle and do certain types of diagnostic testing from a distance and having these minimal types of tools. So it's not the same thing as Dr. Maa, you spoke about before. It's like having an OCT set up remotely, having some sort of fundus camera set up remotely, and to be able to take those images and store and forward them. This is more about how do we now get some information from the patient to be able to constitute what's called a problem focus type of exam or an extended focus exam, to be able to hit at least about 5 of the points or 9 of the points that you're trying to be able to build. And I think that gets back to that question that was posted before by Dr. Kessler. So with the telehealth services, this is more of a synchronous way of doing things. The provider must have some sort of communication that has real time between the patient and the provider. It's usually for established patients, and it's not for new patients. However, audits not going to be conducted during the COVID crisis when it comes to some of the stuff. So everything is relaxed. They're not really monitoring a lot of this stuff. The technology is basically HHS is not going to provide if it's not HIPAA compliant. So FaceTime works, and we can go into some of the other technology in a little bit, but it doesn't have to be HIPAA compliant during this time. So basically, you're using your 99 EM codes when it comes to this. And using these 99 EM codes, it's the same as you would for an in-office type of visit. Documentation is still going to be the same. It should be done in your EHR system, your EMR system, and to make sure that at least you have record of what was done and what tests that you have done. Now, when it comes to some of the facility side there, that this is, you want to have the place of service for O2, which is telehealth. I've seen also some other literature that says it could be the same as in office, especially during the COVID crisis. And if you're going to be doing this, you do need a modifier of 95 for that. That's the only criteria that I have seen so far. So going through with some of this, now we start to think about what tests we can be done. And this is a great place to have a very good conversation, as these are the tests that we're thinking about during a lot of those 99 codes, or as even though 92 codes aren't being done, as we start to think about comprehensive exams. And I think it's a great place to start to then talk about Dr. Kessler's question with the posterior segment overall, what tests that we can be done. And we talk about social distancing, you know, especially, I don't know too many people that do direct op.
Right. So I think this is a great, there's several questions about fitting for glasses as well on the chat. So I think here to the group and the field, we, you know, would sort of encourage a lot of questions and discussion and thoughts about what we're, you know, speaking about. So when I think about incorporating telemedicine into my practice, there's a couple of principles that I follow that will guide me, I think, into determining what type of things I want to do and what kind of tools I want to do. So more of an implementation sort of process. And I think one of the things that you want to ask yourself, number one, is what is your goal? And what are you trying to achieve? And then that answers the question about what could you potentially do? So to go back to Dr. Bryan Kessler's question, if your goal is to try to get a good look at the patient's posterior pole, then you probably can't, or I don't know of a good way practically that you could do that using a synchronous video chat. But if you were trying to evaluate, if a patient had a red eye, for example, and they were concerned about their red eye, you could potentially do that using a synchronous video type of process. Because this wonderful list that Dr. Rogoff has placed on the screen here, you can actually achieve several of these elements enough to build potentially a 99212 with a 95 modifier if you do a video chat with a patient, that you could get more information than just if you did a telephone call, for example. So that was my comment. And there was another question about measuring glasses, as well as some questions about best tool for tonometry. So that's a really good question. I think for tonometry, that's very difficult to do without having the patient in some vicinity. Some creative ideas that I've heard that the field have been trying is some people have been offering drive-through IOP checks, or potentially setting up a asynchronous or a store and forward telemedicine process where you minimize the time that the patient is in contact with you or your staff, but you are, I guess, are with them in the same space, or your technician or someone is close to them such that you can actually get a eye pressure check. So for example, using like an eye care tonometer or something along those lines, and then having the patient as well as your staff wear, masks, for example, or gloves to kind of keep everybody as safe as possible, but still be able to get that valuable information that you need.
So yeah, definitely, as we start to ramp up, getting back into what they refer as non-essential eye care. So it's not the emergency
Right.
aspects, and getting back into comprehensive exams. If you look at some of these tests here about what could be done, and you incorporate this, because we're still thinking about social distancing. So our waiting rooms we're going to set them up much differently. We're going to be setting up the front desk and having staff members in PPE. We're going to be doing different types of disinfection process, not only for the equipment, but we're going to be doing it for the chairs. We're going to be doing it for the desk. We're going to be doing it for keyboards, anything that the patient touches. So we're going to be really vigilant overall to have infection control. So if you think about some of the modalities that we just discussed and look at this list here, and some things are not even on here. And I know that I've discussed them several times in the past about even certain things when it comes to case history. I mean, if you're not utilizing your patient portal of your EHR system to be able to get a case history or types of insurance information and billing information, I mean, that's the perfect place to start to really get some of the information that you need. So case history can literally be done on tablets or sending forms. And during the time right now, I mean, you can set up like a Google form, something for the patient to be able to send out. So this way you're able to grab that information properly. And a lot of times, even if we're going to be doing triage during this session, before we start to open the office, you're going to need a very good case history anyway. And
Yep.
A lot of the practitioners already know you can almost get an idea of a diagnosis just from the case history, and so, that's what we've all been trained to start to think about, how important the case history is. That's not even listed on here. I know that there's a lot of third-party applications for visual acuity that are out there. And really, another thing that we just spoke about before is, and this leads into some of fitting for glasses, is understanding the patient that you're trying to manage right then and there. Dr. Maa, I know we just spoke about that over the past couple of days. But if you have a patient that's coming in for red eye, I mean, there's certain ways you're thinking about that. And when it comes to fitting glasses, there's a lot differences as some of the optician staff and some of the optometric staff, as people will understand, and even just overall, when you start to think about fitting glasses, there's a lot more tolerance of fitting a -1 myope versus fitting a 50-year-old presbyope that's hyperopic and has 4.5 diopters of SIL. So we know that PD and that fitting is going to be much more exact and have a lot less tolerance when it comes to that -1 myope. And I think also with patient coverage as well, when we start to think about disease processes, Dr. Maa, do you think about anything in particular? Let's say if we had, let's call it a mild, well-controlled glaucoma patient, open-angle glaucoma patient. I mean, what kind of things come through your mind that you might be able to think about as we go through some of this list here, and what things can be done in office, when things could be done telemedicine?
Absolutely. I mean, Dr. Rogoff, I think you bring up a really, really good point. When you talk about optical fitting for glasses, I think we can extend that principle that you talk about to to disease care as well. Just like this pandemic has sort of forced us to really triage our patients. We don't want to, but we kind of have to. I think that for telemedicine and figuring out which patients are appropriate for telemedicine, if you want to launch telemedicine in your practice, in the, you know, current COVID situation and then post-COVID is also patient selection. I think that's really, really important. So you're absolutely right. If I'm concerned about a, you know, potentially pink eye or something along those lines, then I think, you know, doing a video-based visit is good. But if you're trying to check pressure because you're trying to measure, you know, you're trying to follow this patient with glaucoma, then a video method may not be, you know, very good because you won't be able to get the information you need to take care of that patient. So you should potentially consider other options such as drive-through IOP or a asynchronous, you know, store and forward method, potentially remote patient monitoring, you know, something along those lines. I think not only deciding what goal you want to achieve, but also very carefully selecting the right type of patient for that. So, for example, in our system, we do offer, we have remote locations where we can provide eye care for veterans. We do it in a store and forward method, and we can do OCT nerves, and we can also do visual field tests at those remote locations. But we do not offer that service to any patient with severe glaucoma because that would not be safe for them.
Yeah.
You know, so just the whole concept that you're addressing, which I think is really important, is just proper patient selection. And I think that there are some really savvy patients out there that if they don't have a, you know, they're not -4 +5 at 158 or something along those lines. And I'm speaking out of turn because I know really nothing about glasses, to be honest with you, but, or fit, you know, any type of, that I leave to the experts. But, you know, that patient probably needs a little more hands-on, careful measure, you know, more detailed measurement. But a young myope might be able to, with your guidance on a video, potentially, you know, measure with a ruler, you know, help measure a PD or seg height if they didn't feel safe coming in, you know, to be measured. This is sort of thinking along those lines. I don't know if that's feasible or not, but thinking along those lines for your, you know, incorporating telemedicine and helping patients get what they need. Yeah,
exactly. Let's go through some of the list here as we're looking at all the different tests and the different points you have to hit on for some of the 99212s and 213s and what have you. So visual acuity, that's a very subjective way of measuring, you know, the vision overall. I know contrast sensitivity, that's not widely used, but highly more indicative of the visual process that's going on. I know that there are some applications out there. I know some people that manage disease like to use that a lot better, especially with cataracts and cataract surgical procedures. They always like to use contrast sensitivity. Have you used a particular visual acuity app that you like? I mean, I've seen a bunch out there that just post a chart, and I guess while you're doing a video chat, you can tell patient to be able to set it up in a particular manner. I know
the Ocular Special Interest Group for the ATA has placed some resources, and they are available on the ATA website for anyone to download, where we provide some tips and tricks for doing a visual acuity using a synchronous video. I have done that on a few patients, and what I've actually done is I've asked them to read me a newspaper or a book. Mm-hmm. It's actually a pretty fun activity, because one of my patients, it was about noontime, we were having our video chat exam, and he was reading from a cookbook and making me very hungry. But you know, if they show you their, you know, the size of their font, I mean, you know, it's not going to be, you know, oh, this is 20/20 -2, you know, no, it's not going to be quite that, you know, rigorous, but most book print is about 20/40. So you can feel fairly comfortable if the patient reads, you know, monocularly a smaller magazine print or something like that they are at least 20/40, if not better. And I think one of the important things that we kind of learned when we were doing this type of exam with the patient is to also ask them if that's different than what they were able to do before. So if there's a big difference between the two eyes, that's going to cue you in that maybe there's something going on. Or if they have a lot more trouble on one eye versus the other. So not only am I asking them to read and focusing on whatever they're saying to make sure it kind of makes sense, The other thing that I'm paying attention to is how easy is it for them to read. And so that, and then if, you know, that's a quicker way to do it. There are definitely apps that are free that you can have the patient download. There's resources where you can have them print out a sheet and then post it in their home. I think I've, you know, Bryan, you may have seen some other, there's plenty of resources out there. There's other resources where people have suggested you mail the patient in advance, you know, a chart, and they can put it up on the wall. Obviously, if you do that, I think that's better if you can do that, because it's, you know, obviously a little more accurate than having them read from a cookbook or whatever they're reading from.
No, and that's great. And then this is also going back to understanding your patient when it comes to certain things as well. And if you have access to your electronic health records prior to that, you can see what the VA was from the previous visit and see if it has grossly gone down. If it goes down a line or two or three, you understand that it just could be just the variation of the testing conditions. So it's really understanding what you can do with just visual acuity. I know with ocular motility, certainly we can do that with the Synchronous and live video conferencing, instructing the patient to look in different directions. We can have them hold the camera closer to really get to see if you're getting the full type of extension, or have them pull it away to see if it's concomitant between both eyes. Visual field, I know that's a little bit more difficult.
Yeah, you bring up a really good point about holding the camera, like changing the camera distance. I think you bring up a really good point about that. And Dr. Rogoff, there's a question from Charles Fitzpatrick about remote vision therapy that I would love for you to answer, since I'm not very experienced with that. But just as a quick, before we get to answering that, in order to, if you have very good light, I think that's a really practical tip that we've learned. You need to have very, very good light when the patient's having the video conference with you to see. But if they bring their eye really close to the camera aperture, you can get a pretty good look. I mean, granted, it's not a slit lamp look. You can get a pretty good look at their cornea, the nexa, the pupil as well. And yeah, you triggered my memory because you talked about, you know, changing the camera distance. And I think that's important for achieving some of the exam elements we may want to do. And do you have any comments about remote vision therapy for Dr. Fitzpatrick?
So yeah, I don't have the question up. What was, so what's the question entailing?
He asked about remote vision therapy. Can CPT 92065 be done as well? You were speaking about motility and things like that. So I think it could be. I'm just—
So with vision therapy, I know there is specific types of coding when it comes to that. I'm certainly not the expert when it comes to the coding for vision therapy. I'm not I don't go into vision therapy as far as part of practice modality. So I don't have a background of the coding itself. I know that there is, when you start to think about vision therapy overall, there are technologies out there for patients that if you diagnose certain type of vision type of conditions, where it could be saccadic problems or pursuit problems, overall, there are technology that can be done for home care. And I know that there's a whole coding section for remote patient monitoring of some of this stuff. And typically it does pay out about $50 a month to monitor a patient if you're doing the evaluation of the testing as well. But usually these different type of technologies, they'll discuss what coding has been done with usually their clinical team to be able to better assist you when it comes to those specialty type of procedures that are being done. Going back to Dr. Maa, you just hit upon those other points where if you're able to get the visual acuity, ocular motility, be able to get into the bulbar and palpebral conjunctiva, adnexa pupils, you're hitting upon at least 5 of those markers to be able to then bill for your EM codes of 99212.
Yes, and then with the 95 modifier.
Yeah, and even getting into some of the other case history aspects too, that counts as well. And if you're also getting into going through their medications as well as their health history, you can hit upon even to over 5, even to the 7 mark. So going on, so let's talk about a little bit of these technology considerations. And overall, I think it's been widely discussed over many different chat rooms and different type of Zoom visits, such as this one, about, yeah, you can use anything from FaceTime to telephone calls. There are different types of telemedicine applications that are out there. I've heard a lot of people use DoxyMe, TeleDoc, Zoom, and Snap MD. And so there's many different ones that you could be using during the crisis right now. But as mentioned, after things start to ramp up and they start to put in place those HIPAA regulations to be compliant, you have to start thinking about the privacy and security rule overall to make sure that everything's in place to be able to still see those patients. I know in the VA, you probably have your own type of system when it comes to monitoring those patients and doing the store and forward, that everything has to obviously, that's a very tight, secure system that you're using there.
We have our own, but I think that the technology nowadays, our technology infrastructure is very good. So you could do it even if you were not in a closed healthcare system.
And I've seen plenty of webinars similar to this where they're demonstrating how they're using some of these applications to just be able to triage patients and post-surgical ones too. And they're able to kind of rule out a lot of it. A lot of it does come down to that case history aspect. And so from the case history and knowing and getting access to their electronic health records really helps them a lot on how to be able to diagnose things. And so that's a good type of tidbit, I would say, to always prepare those beforehand before you start to set up a virtual check-in, or if you're going to be able to try to conduct some sort of 5-point exam or 7-point exam when it comes to some of the telehealth type of considerations here. So we started to go into some of the practical tips that we mentioned. The one thing that I've always, when I started putting some clinical procedures in place for some of the companies that I've done a little bit of work for, the big thing is have the patient prepared. So if you know that you want to have some tests done, like pupil testing, or if you want to, we discussed the lighting, is making sure they have a flashlight ready. If you're going to be wanting to test visual acuity, tell them to download an app, be able to send some sort of VA chart, or I mean, I think you can even download some contrast sensitivity charts. I know you can send AMSR grids if you need to be able to test that for any type of dry AMD patient that you might want to get a baseline about. So what other tips have you started to figure out over the years of doing telemedicine there at the VA clinics?
I think for video, one of the things I've learned is that it matters what type of device the patient is using. So if they're using their laptop, for example, you could display a AMSR grid and have them look at their laptop, and that's a little bit easier to size for them than if they were, say, using a tablet or a phone. So I think, you know, if you're trying to check vision or you're trying to display something on your screen so they can see it as well and use it as part of the exam, knowing what type of device they have is helpful. And I completely agree with what you said about patient preparation. That is, I think, very, very important. One, the patient has to agree to a telemedicine method. I don't think that they would not, but I think it's a good idea to ask for their consent to do a telemedicine method, and then also to, you know, appropriately prepare them so that you get the highest yield out of your telemedicine visit with them.
Yeah, that's very true.
Yeah.
So when also, I'm thinking about post-COVID now, and some of these patients might enjoy being able to get some sort of care.
Or want some care, or need some care.
Exactly, and some of them, you know, they'll all have their different safety measures as they want to be able to leave their home or to get some sort of care, or what they think is maybe emergent care or non-emergent care. They might actually appreciate if you start to be able to continue this type of care with some of these patients. So that's also pretty good, as well, as you start to think about, as we discussed before, infection control, as well as social distancing. These things always have to be taken into place as we're thinking about ramping up and how we're going to get those efficiencies back. I've heard a lot of people say, well, we're now going to schedule from 15-minute exams to half-hour exams. We're going to increase the time, but still it's also that patient comfort, to be able to come in for certain types of chronic conditions, especially in eye care.
Right. That's where I am of the personal opinion that asynchronous store and forward telehealth methods are likely the most useful if your goal is to start to see the patients that have that need to be seen and have disease, but perhaps their disease is relatively stable. And I'm a proponent of, if possible, and if that works in your practice, to potentially have a dedicated, one of my colleagues coined the term a digitally integrated visit, which I think is very apropos. The idea of having the patient go straight to a testing suite where you would be able to get very good information on them. And then keep in mind there, you are going to be close to the patient. You're not going to be 6 feet away. So you are going to, need the appropriate PPE and to disinfect and things like that. But you could check your refraction, vision, pressure, photographs to document the health of the eye, potentially an OCT or visual field, again, depending on what that patient needs. And then that information is kept for you to interpret as a provider later, but that patient gets to go home. But then you've provided that patient very, very good care, and, also try to respect as much as possible the social distancing requirements. They're not crowded in a waiting room waiting. And I think if you integrate some of the things that Dr. Rogoff's talked about, such as using your EMR to get all the history in advance so that your time spent with the patient in person, where you really can't be 6 feet apart is minimized, then I think it's a really good compromise where you're staying safe and your staff is safe and your patient's safe, but then you're still being able to provide a lot of the care that they need. So I'm a fan of that consideration, to potentially consider doing that as well. And some of the things that we've been thinking about, we are going to use our remote sites probably to do some of this type of work. And we will have patients, for example, wait in the car. So, and then they come in straight to a room, and then everything is disinfected before the patient, leaves. And, you're wearing gloves and you're wearing masks and things like that. And so I guess we have 5 more minutes according to Terrence. So wanted to open, I think, Terrence, it's time for, we could talk about telemedicine for hours, really. Should we open the floor for questions, Dr. Rogoff? What do you think? And there were a few on this that I didn't have good answers for, but they're important questions.
So you have them up. I don't have the whole thing up here. So.
Okay, so let's see. One of the questions was, Sheila Mulu asked about site testing on telehealth. So she says, can site testing be done on telehealth in provinces where opticians are allowed to do site testing?
So that goes a lot deeper dive. I would really go to those board of opticianries to make sure that you're in compliance with what those regulations are set up to do. I know, at least on the optometry side, there are some states that have very specific regulations on what optometrists and the relationship that you have to have with a patient are currently set up. So you really have to go to your board to really figure out what you can do and what you can't do, especially if it's in a state where opticians can refract and do a lot of these tests on their own. So that's pretty much how I'd follow that type of protocol.
I agree with you. And Brian Kessler asks about, or comments that there are several websites and apps that can neutralize a pair of glasses. Maybe a good starting point to be combined with visual acuity. Any
yes.
that?
So yeah, and there are, when I've seen the applications, they usually require some sort of product to be used with a smartphone. And so there's ways to test the vision too by using devices that attach to a smartphone or a tablet and what have you. So when it comes down to that, I have not seen them change their business model to be sent to necessarily a patient. They're usually sent to some sort of technician or someone that comes to the house for some sort of home care. Now that gets into a gray area of how you might want to start receiving some of the information and just getting essential patients to come on in, or if you have a population that's very sensitive to be contracting COVID and what have you, and want them to stay at home, you send a technician out there that has everything disinfected, and to make sure that they're bringing equipment to be able to grab information, so home health kits. So I've seen devices that are hooked up to measure or neutralize the glasses as well, to be able to do some sort of vision testing to get manifest refraction. Of course, there's home type of kits or travel kits that are utilized usually for a lot of philanthropic work, where there's handheld non-mydriatic cameras, there's handheld slit lamps, eye care tonometers and handheld tonometers. I know the Diaton's another one that can be used for that. So when you start putting those pieces of information together, that is definitely another strategy to think about during post-COVID, as you have a certain population that may not feel comfortable coming into the office as well, and you still have to monitor some sort of chronic condition, that you might be able to send a technician to that patient's home. So as far as any applications to measure that itself, I've not really explored that as much, but I do know that there are attachments you can add to the actual smartphone devices that can do that.
And I would add that it's probably worth trying. And again, we've talked a lot, Dr. Rogoff and I've talked a lot about appropriate patient selection. I think it's worth trying, because you'll learn something by trying it, even on yourself potentially, or that will help you take care of patients better. And I think, again, it's a matter of patient selection. So if that patient is, has a relatively recent pair of glasses, seems to be seeing pretty well, and is the right candidate to be able to do that, and you can define that however you wish, like they have the right technological know-how, they have the right equipment to do that. I think it's worth trying, because you have really nothing to lose by trying. You're not going to hurt the patient. Yep. And there's an additional question about shields for autorefractors and cameras and OCTs. I will say that from my team, what we've been doing is we have been working with the manufacturers of that equipment about the best way to clean and disinfect that equipment. Some of these companies, I'm aware, will provide, for example, like for your slit lamps, for example, they will provide like slit lamp shields to help protect you when you have to be in that close proximity to the patient. And I do believe that we have some very enterprising team members that can create a barrier using those old slide holders that you can put over to as an additional barrier. But I think wearing masks and gloves is, and following those guidelines that are being published by AAO and AOA are probably the best. I would follow those. That's what I'm following.
I know, working with ZEISS, I know that they've sent out slit lamp shields, and they certainly have a website, Med Support, where it comes to their disinfection product of their different types of equipment as well. So yeah, really go to the manufacturer, and depending on what you have, hopefully they have some sort of help page during the COVID crisis to make sure there's different disinfection methods to be able to use during this, and how to make sure that you're minimizing any type of exposure to the patient.
Right.
Well, excellent. Well, Dr. Rogoff, Dr. Maa, thank you so much for that discussion. I can tell everyone enjoyed it. I'm getting all these text messages and emails asking, is there recording available? So the answer to that question, yes, you can always go to the Vision Expo website. On the tab, this is Eye to Eye series, will take you to the schedule of events. And we have our YouTube channel, which all of our Eye to Eye coffee talks are published there. So just give this one at least until the beginning of next week, and you'll see that updated on our YouTube channels as well. So we want to thank you all for doing this. Next week's coffee talk is again Wednesday at 12:15. You will see there that next week's coffee talk is going to be entitled Secure the Bag, which will be presented by Marge Axelrod. And this is a very unique coffee talk. And this will be talking about to vendors and how they are supporting retailers and practices, and how they are going to be participating in changing their best practices post-COVID-19. So join us next week, Wednesday at 12:15. Now, again, we have Coffee Talk, which is part of our Eye to Eye series. We also have Friday at 4:15, our happy hour, which is geared more towards the creative side of the industry. So this week's happy hour on Friday will be a speed dating happy hour with Wendy Sally, who is the owner of Sally Opticians. She's been in business for over 30 years, and she will be taking questions. We have a few mentees who will be asking her questions, and please join us in. And don't bring your coffee to happy hour. Bring your adult beverage of choice as well. So thank you again. You may have noticed also a poll may have popped up. We asked you before you log off, please fill that poll out. And we want to thank you all for participating. And thank you for the ones who have been supporting every week. And we see all of you from Lagos, Nigeria. Thank you, Jessica Hall. Thank you, Dr. Zach Hines of Beverly Hills has been here every week. Thank you, John from Alem. Thank you, Dr. Solani. There's so many, Ken Mellies, Gary Black, so many people that have been joining us. We really appreciate your support. So thank you again, Dr. Bond, Dr. Rogoff, thank you. We appreciate the American Telehealth Association for putting this on, and we will see you all next week for Coffee Talk or Friday for happy hour. So signing off.
Thanks, everyone.
Bye, everyone. Thank you. Stay safe.
Hey, I'm just gonna stop the recording.
Okay.